Hi everybody, so this presentation is going to cover pediatric emergencies for EMS 1113 pediatric first aid and CPR. First we'll discuss some developmental characteristics of infants and children. The pediatric age category is considered from newborn up to 1 year old, whereas a toddler after they turn 1, considered taller up 1 to 3, and then preschool from 3 to 5. Then considered a school age at 6 to 12, and then an adolescent at 13 to 18 on average, considered an adolescent once the child hits puberty. So as we all know, there are some major anatomical and physiological differences between adults and children. Understanding these differences will help you go and care for kids, as they are just a little bit different than caring for adults. First, with the head. Kids are great big bobbleheads. So when they're laying flat on their back, as you can see in this picture, the big back part of the head will push the chin down. That can end up compromising the airway in a kid that may already have an airway issue. So laying the kid on the back, need to have support under those shoulders. The head is big and heavy on those kids. It's proportionally much larger than the rest of the body as compared to an adult until they hit about the age of 4. If they do hit their head, always be suspicious of head injuries. Never delay care for seeking treatment on head injuries. Especially little babies, the fontanelles, those little soft spots they have from where their skull isn't completely formed yet, be examining those if a kid does have any head injuries. If you see any kind of fontanelles pushing out, very indicative of a head injury. Also with medical emergency stuff, if the fontanelles are sunken in, it could be dehydration or out, different diseases like meningitis, different things. So if you see any kind of stuff going on with the fontanelles, be very indicative that it is a serious condition. Airway and respiratory system, the mouth and nose are very small and they're easily obstructed. So an adult could stick a crayon up their nose easily and still be okay. That little kid sticks a crayon up her nose, this can be completely obstructed. With having that great big head, the kids also have a really big tongue that takes up more space proportionally than what an adult does. So that tongue can easily obstruct that airway. So lay on your back and those snoring respirations, that tongue can end up obstructing the airway of that kid as well, laying on their back. Most of the time kids, they do breathe through their nose. So that's why they're considered nose breathers, belly breathers. The trachea, the windpipe, is softer, more flexible, and can be easily obstructed by swelling or foreign body obstructions. Just like the analogy of the anaconda that eats that water buffalo and has a great big bulge. It will end up doing that when it's trying to not necessarily go down the wrong hole per se, but when everything starts going down the right hole and it expands and pushes against that windpipe. They have a soft chest wall, so that diaphragm is more involved in their breathing. So whereas adults, we've got more muscles and more solid ribs that we can use to open up our thoracic cavity. The kid uses that diaphragm. The wee little babies, those neonates, their ribs are more box-like, whereas adults and younger kids' ribs become more rounded. Neonatals are basically, the ribs are just kind of cartilage. They really haven't gotten their shape yet. So sometimes having that limited ability to take deep breaths, where adults, our rounded ribs can expand, straighten out, flex, open up space. Those neonates don't really have that capability. And since they are all nose breathers, be sure to keep that nose suctioned out real well. So using those little bulb syringes or whatever kind of suctioning devices you may have, keep those things cleared out. A lot of times I think kids are having a lot of problems breathing. They've just got icky runny noses that need cleared out. Also, considering keeping that bobblehead leveled out by padding under the shoulders, either padding too much or not padding at all can result in flexing and bending of the neck, which also can result in its own airway obstruction. If you suspect a kid of choking, don't ever do a blind finger sweep. Only stick your finger into their mouth to pull something out if you can actually visibly see something. If you put your finger in and you don't see anything to pull out, you could end up shoving that obstruction further back down in or causing some airway issues, as the tissue in the little kid's mouth is very sensitive, so even the slightest fingernail could cut it and then cause them to bleed, causing even more of an airway obstruction. So in the diagram here you can see in below how an adult laying on their back, the windpipe's fairly straight, whereas a little kid has more of a bend to it without any kind of padding. You've got this great big cow tongue, and they're taking up a whole lot of space in the mouth, where if you look at the adult here, the tongue doesn't take up as much space. So a big tongue laying down on the back of the throat and are laying flat can cause issues. Now, thinking about that, that's in the kid who could be unresponsive, is just not holding their own airway open well, whatever it may be. A lot of kids sleep on their back, and it's not a big deal. The chest is less developed, so it's more elastic in young kids. So it's hard for the real young kids to break ribs, things like that, because their parts are still pretty flexible. Once again, those infants and little kids are abdominal breathers because they don't really have those hard ribs yet to be able to pull air down into the cavity. And those abdominal organs are less protected than in adults. Intestines, other soft organs that aren't covered by the rib cage, just because adults do have a thicker muscular wall over those organs than what the kids do. Body surface of kids is much larger than adults in relation to the body mass. So they're more susceptible to intolerances in temperature changes of being hot, being cold, than what adults are. So in a basic analogy, as an instructor once said, a little kid is basically a really big house with a really small furnace. So their temperature regulation is very inefficient. So remember that when you're outside with a kid and you're both in t-shirts and you're like, oh man, I'm a little cold, but if I just get out there I can tolerate it pretty quick and without getting too miserable. Well, if you're getting miserable because you're too cold, that kid is already way behind and they are way too cold. So those kids need to stay bundled up, keeping them warm, just not too warm. Another reason the kids are susceptible to intolerances of temperature regulation is that they do have a whole lot less blood than adults. So a little bit of bleeding in an adult, which could be considered no big deal, if a kid would lose that same amount of blood, could be considered a life-threatening situation. So in perspective, that 9-pound newborn has about the same amount of blood in their system as a can of soda, whereas a younger child, about 60-pound range, about 2 liters of blood, and 125-pound adult, 2 liters of blood. So we all know that each age group kind of has its own personality. We hear of the terrible 2s, the even more terrible 3s. Each age group and each gender, each kind of have their own quirks and personalities. So some kids may cry when they see you because you're a stranger. Some kids are open and never meet a stranger. So each child can be a little bit different. Just never let the potential of upsetting a child prevent you from delivering appropriate care. Remember, a kid who is crying is a kid who is breathing. So that's always a good concept to think about. So when you interact with that little kid, always identify yourself and let somebody, let the kid know that if there's an emergency, that their mommy or their daddy or both are coming. Get on the child's level. Don't be big and intimidating to them. So get down, kneel at the child's eye level, talk to them, soothe them, let them have a toy, try to make them laugh, give them something to distract them. Sometimes with injuries or ailments with kids, distractions or laughter is the best medicine you can provide. So give them a big smile, touch and hold their hand, tickle their feet. Like I said, try to give them a giggle. If you're going to do anything to a kid, like take their temperature or anything like that, always explain what you're going to do. Kids are very curious. So if you explain to them what you're going to do, what's going on, let them be part of what you're doing. Try to involve them. It will definitely serve as a distraction and take the kid's mind off what you're doing, or possibly that the kid is very sick. And most importantly, never lie to a kid. Kids can see right through that stuff. Granted, with Santa Claus and other big stuff like that is one thing, but if you're fibbing to them, they will catch on to it. Or if you lie to them, they will always remember that and think ill of you if something bad comes out of the situation. With adolescents, they should be able to tell you exactly what happened, what's going on, how they feel. Dealing with them in front of parents if need be. If you ever would have to ask questions around parents or other adults, sometimes they're maybe not so communicative or cooperative about what's going on as if they would be if you just have them one-on-one. They're also at that age group, they're getting a little bit sensitive, thinking about what other people think of them. So sometimes it's better just to get kids one-on-one to really see what's going on, pull them away, and get them in confidence, and they will tell you more about what's bothering them or really what's going on. One of the hardest things about pediatric emergencies is supporting the parents or other people involved with caring for that child. Some can go into denial, shock, crying, screaming, just throwing complete tantrums as if they were a kid themselves. People, are very biased, and more, not necessarily biased, but more generally concerned of kids than they are adults. So sometimes when trying to care for them, those emotions come out and can, in like better terms, mess up trying to care for the kid because of the emotions and everything involved in it. So sometimes trying to get other people calmed down to help take care of the kid is one of the biggest issues. So now we'll talk about how to assess that pediatric. So 2 viewpoints when dealing with the kids is from the doorway. What do you first see whenever something's going on with the kid? How do they generally present to you? And then the rest of it is what you're actually seeing up close. So, from the doorway, that's having the blinders off, kind of taking in everything that's around them, and then the rest of it's up exactly with the kid. So biggest concepts of assessing the kid are 3 things: appearance, work of breathing, and circulation of skin. This all ties into the pediatric assessment triangle. This is the common thing that's used in teaching how to assess kids in EMS, so it just kind of carries over into everything. So first thing, appearance. Looking at them, just what do you see, what's kind of sticking out? Their tone, kind of how are they holding themselves up? Are they limp? Are they, do they have good structure setting up right, or do they look like they're about to pass out? Their interactiveness, are they talking to you, or are they acting their normal self? Consolability, if it's a really young baby, can you pick the baby up and try to soothe it, and the crying start to slow down, or is nothing you doing working, just making it worse? The look and gaze, are they giving you that million-mile stare, or are they actually following you? If you're talking to them, are they looking at you, or are they just looking through you or around you? With speech and cry, are they able to talk? Do they have any kind of different? Does their speech sound a little bit more hoarse than it normally does? Does their cry sound funny? Or are they talking and crying at all? With work of breathing, do you hear any weird breath sounds? Do they have any kind of just weird noise coming out when they cough or they cry or they talk? Do they have any kind of weird body positioning? Is their head starting to go into a bob with trying to breathe? Or is their nasals flaring? Do they have muscle retractions around their neck or around their chest? They really just trying to put more effort into breathing. And with circulation of skin, what does it look like? Is it pink, warm, and dry as it normally is? If you do a capillary refill, push from their fingernail bed or on like the back of their hand, whenever it turns white, then goes back to pink, is that normal? And that generally within about 1 to 2 seconds when you do capillary refill, it should go from turning white to being back to pink. So your primary assessment is just forming that general impression. What do they look like? Do they look sick? Do they look hurt? And then rapidly identifying if a kid is critical. That's the biggest thing. Those big first split-second decisions of, is this kid bad? Do I need to call 911? Am I okay just calling the parents? Or what exactly do I need to do to take care of this kid? So checking those basic things of the mental status. If there's a sign of mental status changes, that is the number one indicator that something is very bad. Those require 911. If there's ever a kid that is just not quite act themselves or confused or anything going on, need to call 911. How are they interacting? Are they just being themselves or not? So form that general impression. Do they respond to you? Do you talk to them? Back to that pediatric assessment triangle. Are they looking at you, interacting with you? The whole body positioning and the rest of that assessment triangle. As I said, the first indicator that something is bad with the kid is that change in mental status. So when you assess that mental status, it's first checking to see if they're alert. Just simply saying their name. Hey, are you okay? And that's kind of from a little bit of a distance. As you're getting closer to the kid, if you are away from them, is a verbal. So yelling louder, see if that perks them up. Maybe they're just deeply asleep. And then if you're yelling at them doesn't work, you need to induce some pain. So take your fingers, rub it in their sternum, pinch on their fingernail beds, or gently tap the feet of the really young ones. And with pain, I'm not talking, to go and shake them or slap them and try to really give them some legitimate pain, but just some kind of induction of pain, like rubbing their sternum, the nails, things like that. Next is assessing that airway. So after you assess their mental status, then you go to their airway. Are they breathing? Checking those A's and the B's. See if they're breathing. If not, you may need to just open the airway. So take their little head, lift it up in the air a little bit. So from their back, mouth goes straight up in the air, and then pat underneath those shoulders to get that tongue up off the back of the airway from those great big bobbleheads. Just be sure not to extend it too much. So when you're looking for assessing of their breathing, you're looking at that mental status and see if you see anything like the flaring nostrils. Are they blue around their lips or around their nail beds? Do you see any kind of extra muscle work going into it, like the head bob, any kind of muscle use around the neck, around the ribs, their belly? Are they able just to sit still and breathe? Or if they're having to move, the more the kids move, the more muscles they use trying to breathe, the worse that it becomes. So you're looking for good chest expansion, both sides of the chest coming up and down. Checking for that work of breathing. Is there any other kind of muscular use into it? Sounds of breathing. Do you hear any weird noises coming out of them while they're trying to breathe? Sometimes the crazy sound you may hear is just the snotty noses because kids are nose breathers. So if you hear any weird sounds, suctioning out that nose. Did that make anything better? And then a breathing rate. Are they breathing way too fast? Are they breathing way too slow? And their color. Is their skin pink? Is it warm? Is it dry? Do they have good normal pulses? So in little kids, you're checking those pulses at the brachial artery, just in between the elbow and the armpit. right along where the humerus bone is, the upper bone in your arm. See if they've got good pulses there. Remember, with kids, a pulse over 60. If they're unresponsive and their pulse is less than 60, they still need CPR. Checking that capillary refill. When you push down their hand and it turns white, whenever you lift up off your thumb, does it go back to being pink within just a couple seconds? If that's getting delayed, that means they have issues with blood flow somehow or another. So whether they're very, very sick, they've got an infection, or if they had an injury and they were bleeding, checking that capillary refill will let you know how well their blood is circulating. So now we'll talk about some ways to identify those priority patients, ones who need 911 called, who are in need of definite attention. So ones who just give you that poor general impression or just really go by your gut. If they're unresponsive, or you have that change in mental status of not recognizing a parent or their primary caregiver or teacher, ones who are not consolable, like that pediatric assessment triangle, their tone, the consolability, those things, any of those that raise a big flag could be considered a priority patient. If they have a compromised airway, if they've been choking or something, if you hear any kind of weird breathing, or for labor breathing or breathing too fast, anything big going on with the airway, possibility of shock if they've been bleeding, or if their capillary refill just isn't very good, any kind of real blood loss other than scrapes and average boo-boos that a Band-Aid can take care of. So some considerations when assessing and doing a physical exam on a pediatric patient. Start with the toes and go towards the head. Little kids, if you're trying to look at them and you're looking at the head first, it could tend to freak them out, and then the whole rest of the assessment could be worse. So if you can start around the feet, if you want to check them head to toe, feet to head, checking at the toes, touch and tickle their feet, try to get them some laughter, ease them up, and then go all the way up to their head, checking everything else out. And if you need to, if you have to derobe the patient to be getting a good look at them, let them know why you're taking their clothing off, or why you're having to pull their shirt up or pull their pants down. When looking at the head, don't poke or press on those fontanelles. If they look a little puffed out or sunken in, don't touch them. There's not much barrier between that and their brain. When looking at the nose and ears, look for blood or any kind of clear fluids coming from the nose and ears. If there's blood or fluid coming out of the ears, be suspicious of a possible brain or skull injury. Now, it doesn't always mean if there's blood coming out of the nose, if they bust their nose, that they've got a brain or skull injury. Think about that in the back of your mind of how bad was their injury. And also with that, if blood is coming or stuff's coming out of their nose, be sure to try to keep that cleared out, or if it clots up, get that stuff cleaned out, because that could cause airway issues in the kids. Their neck, very vulnerable to spinal injuries, since they've got that great big bobble and heavy head, can damage their neck. Those muscles and bones, they're not quite as developed or as secure as the adults, so a lot more susceptible to injuries. So when examining that airway, so you gotta have the underneath the shoulders padded up. That puts all the head in line, gets the mouth straight up in the air, keeps that airway open and patent. Maintain that neutral sniffing position for kids. Now, if they have suspicion of a neck injury, you have to be very cautious with this. Try to keep their head in line if you're going to pet on there. Don't be manipulating and moving their head if you believe there to be a neck or spinal injury. Looking at the chest, making sure the chest is coming up and down as they breathe. Looking for any kind of bruising or any kind of just weird movements or pain as you feel around on their chest and in their belly. With the belly, note if it's rigid, if it's starting to stick out. If you rub on their belly, is it sore? Is it becoming harder? If it is becoming harder, it could possibly be blood loss or something into the abdomen. And the pelvis, seeing if it's stable. Kind of squeeze and touch on their pelvis to make sure that it's stable, that when you push on it, that nothing hurts. In those extremities, check the capillary refill in their toes and their fingers and feel them for pulses. See if you can feel pulses in their feet or in their hands to make sure that they've got good circulation there. Pulses in kids are very hard to find, so using that capillary refill would be very good for the general layperson. And motor and sensory. Can they wiggle and can they feel? With their feet, if they're in a lot of pain, make sure they can wiggle and feel. If they possibly broke an arm or a leg, make sure that past or below that site of injury that they can still feel, they can still wiggle their fingers or toes, and they still got good circulation down there. So some special concerns. Maintaining that airway is huge. So if there is a possibility of a spinal injury and their airway is compromised and you have to open their airway, we do what's called a modified jaw thrust, where you'll basically put your thumb on their cheek, your fingers on the corner part of their jaw, and lift their jaw straight up in the air. It's not much of a movement at all, doesn't take much effort to do it, but you want to do that instead of lifting their head or trying to pad under their shoulders. By doing that, it lifts the jaw out, gets the tongue up off the back of the airway, because you don't want to be rocking their head back and forth if they do have possibly a neck injury. Clearing out airway obstruction, as I said before, if you can see it, reach in there and get it out. Don't just do a blind finger sweep. For little kids, to clear airway obstruction, get the head below the butt, 5 good hard back slaps, turn them over, supporting the head, and then 5 abdominal thrusts. If they're coughing, just continue to let them cough and hack it up. They might throw up, but that's what they do. So once you got them turned over, just have to do those chest compressions the same way you do CPR. Couple fingers right on the lower part of the breastbone, 5 compressions, turn them over. There are some common causes for shock in kids. I know a lot of people use the term that somebody's in shock, but shock is a true medical emergency. So reasons that kids couldn't get shock: if they have severe diarrhea and vomiting. That doesn't mean just because they throw up or have diarrhea once they're going to go into shock. If they've had severe diarrhea for days, vomiting, and they can't stop, they can go into shock because they're losing all the fluid out of their bodies. Infections, major trauma, even resulting in blood loss, allergic reactions, not, that around a cat that are itchy and watery, like they get stung by a bee and they go into anaphylaxis and they swell up and turn blue. Poisoning, they got into some kind of cabinet they're not supposed to, in a very rare situation of cardiac events. So signs and symptoms you can see for shock in kids. They can be pale and cool, get sweaty, their pulses become weak, they're unresponsive, that delay capillary refill, and breathing fast, or just anything into that pediatric assessment triangle for skin tone or the mental status changes could be an indicator of a patient in shock. So how to care for it? Just make sure that they got an open airway, that they're breathing. If they are bleeding, try to care for any kind of bleeding that you can. Keep them flat and keep them warm. Get them wrapped up in towels or heavy blankets, keeping them warm. And also be wrapping up their head, and because the body will lose the majority of its heat through its head. So keeping the head wrapped up and keeping her body warm, and avoid any kind of rough handling. Just keep them calm, call 911, keep them wrapped up, and they'll get to the hospital where the ultimate care will be provided. So we'll talk about some medical emergencies. Respiratory disorders, airway is a big thing always. So there are numerous types of respiratory disorders that can affect young kids. So big thing is recognizing that first signs and symptoms of difficulty in breathing. It could be from anything as simple as a cold up to something more serious like epiglottitis, croup, those kind of things. So again, looking for nasal flaring, retractions, any use of any kind of muscles, or hearing any kind of weird sounds such as stridor, which is a really high pitched sound that they'll make generally on as they breathe out, but it can also occur whenever they're breathing in. So just don't get that confused with whistling of the nose from snotty noses and stuff. So it's generally coming out of their mouth. Or if they're grunting, really struggling, having a hard time breathing. If you see a little kid breathing more than one time every second, very, very bad symptom that they are having major problems breathing, to be breathing that fast. And then again, an altered mental status, as that's the first indicator of anything being bad. If their breathing pattern is starting to slow down, slower than it should be, not, the kid was crying, hyperventilating, and now they're slowing their breathing rate back to where it should be. So anything lower than where it normally is, or anything irregular, that they're breathing fast and they'll breathe slow, then they'll breathe fast and they breathe slow, just by breathing patterns. We all know when kids cry that they can sometimes kind of hyperventilate themselves. Decreased muscle tone, they're starting to become limp, or you're starting to see that poor capillary refill, or their heart rate is starting to drop. So some types of respiratory diseases: croup, generally they'll have a mild fever and some hoarseness. They'll have this seal bark cough. So as they cough, it just sounds really deep in tone. They'll have difficulty in breathing. They'll be very restless, and they could be slightly pale with some cyanosis, meaning bluing around the lips or the nail beds. Epiglottitis, sudden onset of high fever, very painful swallowing. So since the kids can't swallow, they'll generally just be drooling a lot. They may have themselves in a tripod position if they are that age, to where they're kind of setting up, hands on their knees, leaning forward. They'll sit very still because moving anything around the neck is going to be very painful, as it's severe swelling in there. With this, don't try to suction that stuff out. Don't put anything in these kids' mouth. Their airway is already obstructed, or swelling, so don't put anything in there. It can worsen the swelling and cause an airway obstruction. Some other disorders: kids with a fever, remove their clothing if they're very, very hot, and just kind of get them cool. So if they're in a big onesie and they're really hot, get them out just in a cooler area. Just normal air conditioning stuff will get them calmed down. Don't go and dunk them in ice water or rub anything over them. Just let them passively cool down. But check them for shivering. If you get them cooled down and they start to shiver, they need to be warmed back up. Sometimes when kids get really high fevers, they can have a seizure. If that occurs, major medical emergency, call 911. Again, don't submerge them into ice water or put ice packs on them. As we've talked before, that kids are very intolerant to wild temperature changes. So just let them passively cool down. Just get them out into their underwear, let them cool down. And don't use rubbing alcohol to try to cool the patient off. That will take too much body heat away from them. If a kid does experience a seizure, whether it be from the high fever or some kind of chronic ailment, big thing is just to make sure that they're breathing, keeping that airway open. Put them on their side after they've finished seizing, and just be cautious for vomiting. Just keeping an eye open for their breathing and circulation and whatnot. Now with the mental status, Generally, all patients that come out of seizure have an altered mental status. It may take them several minutes to get back to their normal self. So just be thinking that in the back of your mind, that just because their mental status is off, don't get freaked out that when they come back, that could be very normal. But if you do have an altered mental status in any situation, big indicator that something's just not quite right. Even with that seizing patient, when they regain consciousness and their mental status is a little off, it could remain off depending on if they've have diabetic issues or various other underlying things that could contribute to that seizure. So if you do have a mental status, you got to do a little bit of detective work and see maybe what's going on. So doing those assessments, checking temperatures, making sure that they got good capillary refill, and if all else fails and you're worried, call mom and dad and call 911. For poisoning stuff, you can contact the 911 centers or the National Poison Control line of 1-800-222-1222. Call them. They can walk you through all the simple instructions of what to do if somebody has experienced some poisoning. The old rule of thumb was just make them throw up or give them a glass of milk. Well, for one, we don't want to just ever make anybody throw up. You can end up having airway issues then. And two, it's just a mess, and you need to leave that stomach acid down where it should be. Two, with giving milk, that is a very common thing, but you need to make sure that that milk's not going to cause a chemical reaction with whatever that they became poisoned with. Then just keep them simple, and not simple, but just keep them calm and relaxed, and call 911, call mom and dad. A rarity is sudden infant death syndrome, or SIDS. This is basically just a classification for kids who have died and there's no known reason of why they do. Sometimes it can just happen, so they are very rare. Generally it's a known cause, but they do happen. So they'll be treated just as any other cardiac arrest. So opening the airway, checking responsiveness, checking for pulses, checking for breathing, and then beginning CPR and calling 911 immediately. Always try to do CPR unless there are signs of obvious death, such as rigor mortis. The biggest thing with this will be giving emotional care to all those involved. So some trauma emergencies, going back relating to the head, that big old heavy head, say they get slung off merry-go-round, they got the big heavy head that can propel them forward and kind of help and will sling them around. The chest, not developed nearly as well, so those elastic ribs don't provide a whole lot of protection as where adults' big solid ribs do. And always be checking for any kind of deformity that could be a very big indicator of something bad, especially in the chest area. Abdomen, looking for that diaphragm and breathing, checking it out, just rubbing around their belly, see if anything hurts or how it feels overall, and just keep an eye out for vomiting to make sure it's not going to hurt or compromise their airway. Burns, if a kid gets burnt, first thing to do is rinse it off. First and second degree burns, where first degree is your typical kind of sunburn, just red. Second degree is when there is a blister, and third degree is black and charring. For first and second degree, just run it under some cool water and wrap it up with a non-adherent sterile dressing. Just don't cover it up with just anything. First aid kits, burn things, clean wraps, make sure it's just not going to stick to them. If any burns around the face or the neck, bad stuff. Swelling and edema could quickly occur, compromising that airway. For kids, any kind of burn to the hands, feet, face, and or genitalia is considered significant, and critical. So some other types of trauma can be related to child abuse and or neglect. There's different types of child abuse, of course. There's psychological, the emotional abuse, can be tied in from all other types of child abuse, can cause that psychological, or it could just be primarily psychological. Neglect, that's a big, almost nearly a subjective thing of what neglect actually is, because not all kids are always raised the same or have the same kind of benefits or resources that other families do. There's physical abuse and sexual abuse. With physical and sexual abuse, you've probably all heard numerous stories, seen all kinds of articles or stuff all over the interweb about just all kinds of bad stuff that happens to kids. They're generally also called battered children. There's all kinds of other new terms going into this stuff, and not necessarily physical abuse, but non-accidental pediatric trauma. So, with sexual stuff resulting from, sexual exploitation and just, showing themselves, or actual physical sexual intercourse, and different things like that. Some signs of possible physical abuse could include slap marks, bruises, abrasions, cuts, incisions, different things. Bruising to the shins, elbows, forehead, the chest, on the front side on kids. That's generally pretty normal. But if you start seeing any weird marks on kids, or bruising in just odd areas, or bruising in the size of the shapes of hands or other inanimate objects, could be a big indicator. Sometimes kids get bruises on their butts from spankings. That's one thing, but bruising, just severe bruising, multiple places, big indicator. Broken bones, really young kids, to break a bone is very hard. Any type of head injuries, changes in those fontanelles. Really, you see any kind of injuries that just don't really fit the normal critique of how kids get hurt. Seeing bite marks, burns, or kids that just get dropped off to daycares or different things with that mental status change, indicator that something may not just be right at home. So, seeing here a picture of some possible child abuse, little bruising here and there is one thing, but then noticing the large bruising on the right butt cheek where it looks like they were struck with something fairly big, as the bruise is over a wide spanner area, and those are pretty deep bruises. Bite marks, some more signs of possible physical abuse. If you see obvious outward signs of sexual assault, changing a kid's diaper, you notice something that's just out of the ordinary, any kind of injuries to the genitalia, or if you just see any kind of discharge coming out of them that's not quite normal. Some indications that an adult could be abusing them is the inappropriate concern about the child. You've probably all been around people who you think just don't really care that much about their kid, and it always causes concerns. So as I said before, that adult that drops the kid off at the daycare and it's dirty and just isn't acting themselves, and the parent who should know them the best has dropped them off that way. If the parent has a temper or anger problem, just seem emotionally unstable, to where wild mood swings, they're happy, they're depressed, happy, depressed, or any kind of indicators of drug or alcohol abuse. If you do suspect child abuse, you have to report it by law. Don't be confrontational with the parents or who you ever believe is abusing the kid, but you have to report it to the authorities. If you do suspect the child has been, say, sexual abuse, don't let the kid go to the bathroom, because the whole child is a crime scene. So don't let them go. Try to wash themselves, do anything. Preserve all the evidence that you can. Don't let them drink any water. Don't try not to let them go to the bathroom. Um, just try to keep them as they were when you found them, and call 911. You can always try to ask questions from the adults. Like, hey, I noticed they got a big bruise on her back. They looks like they took a pretty hard fall or something. You try to play dumb, but try to figure stuff out at the same time. And then if the child is able to talk, pull them aside separately. Let them develop some rapport with you, and in confidentiality, tell you what's going on. And if you find anything, you have to report it once again. By law, you must. If you do believe it, use in terms that you suspect or you believe. You don't say that you know that they did this. Just say that you suspect child abuse or different things. West Virginia does have a 1-800 number that is monitored 24/7 to report child abuse. So in summary, we'll kind of go over a synopsis of all pediatric emergencies. Pediatric emergencies are among the most stressful situations one will ever encounter in their life. A lot of times people identify a child that they're caring for in relation to their own child. Like, well, I have a kid just about that age of the house, and they're trying to take care of a sick or injured kid, and they see that it's their own kid in the back of their mind. You may be anxious about dealing with the kids, but try to put all the distractions aside and care for the kid when the need comes. Most serious stresses are over a very sick, injured, or abused child, or a child who may die later on. So the stress is a very significant thing. So there are counseling services and stuff out there if you would ever need to talk to somebody about situations you may have been involved in. Care with kids mostly consists of just using the knowledge you know about caring for adults and applying to little kids. In all situations, never halt from calling 911 or calling for help. Also, just as I said before, try to comfort the kids, provide some emotional support and physical support, make them laugh, try to console them until mom and or dad or 911 arrive.